Hi, I'm Shelley Wood, the managing editor at TCTMD. This is On Record, regular program exploring hot topics in interventional cardiology and beyond. My guests here today are Dr. Ryan Madder, Dr. Jennifer Tremmel. We're talking about radiation in the Cath lab. This is a topic both of you have a long-standing interest in. I've been watching as an outsider for some time now. What strikes me is that people are very interested in this topic, but I'm not sure what they're doing about it. So that's our topic. Dr. Madder, you have looked at this. We talked before we started filming about the fact that there's so much innovation and technology in this space. Why aren't people protecting themselves from something they know is causing harm?
I think there are a couple of different angles to look at this. I agree that there's been interest in radiation safety for a long time. I think a lot of that has been focused on the risks that we face, which have become, I think, clearer and clearer as time has gone on based on studies that have looked at risks that we face in the Cath lab. One of the exciting things, though, is that there's a lot of technology that's being developed to help address the problem.
Right.
And one of, I think, though, the limitations to getting that technology into Cath labs, I think a lot of interventionalists who have an interest in making their Cath labs safer, run into roadblocks with their administrators who may not be interested in paying for the technology to make the lab safer. And one of the things that I actually learned earlier today was that there was recently a lawsuit filed in Indiana, in Evansville, Indiana. There was unfortunately a physician there who worked in a fluoroscopy suite that developed a brain cancer and died at the age of 46. And apparently his family have filed a lawsuit against the hospital claiming that the administration did not do enough to promote radiation safety.
Wow.
And it's a shame that it may take something like that to polarize the interventional community and hospital systems to really do more to protect physicians, staff members in the Cath lab, and our patients. Right.
So just to clarify, though, this is unequivocal evidence that this work that you both do does lead to the potential for brain tumors. That's not in question anymore. Is that correct?
I don't consider the cancer risk to be in question anymore, or cataracts, or we may talk about musculoskeletal issues as well. So I think the data is quite clear.
Yeah, one of the, I think, most compelling pieces of data to look at the risks that we face was a study published by El Sayed and colleagues in 2017 in Circulation. And they looked at vascular surgeons doing a singular, one endovascular AAA repair in a fluoroscopy suite and drew blood on those physicians before the procedure, immediately after the procedure, and a day later. And what they demonstrated was very convincingly there's a rise and fall in DNA damage biomarkers that you can measure after a single fluoroscopic procedure in a physician.
Okay.
And I don't think that those data can be disregarded. I think that evidence like that is so important, showing that every single procedure may carry risks with it in the Cath lab.
So the hospitals can't argue that this isn't a thing, but they could be doing more about it. And this is an area you've taken an interest in, some of the types of technology. Some of it's quite cumbersome and I'm sure then expensive, but not all of it.
Yeah, technology is definitely changing a lot, and I think that has boosted our interest. It used to be simply, you change some buttons and that's as good as you could get. So obviously shielding technology has improved, but still can be a little bit cumbersome. Being able to use the robot is another technology that people like. It does have a learning curve and it doesn't necessarily protect our staff or change radiation to the patient. And it's not just us, obviously, that's in the room. So, one thing I talked about yesterday is eye tracking, which is a very cool technology where basically all of the radiation that's in our periphery, we don't need.
Or you're not looking there.
We just need to attenuate that. We do want to still be able to see in the periphery, but we don't need to irradiate the whole area to the same degree, basically just that 5% where we're looking. And so Control Red has a technology that basically in real time will move around where we're looking and keep our focus there and make our image just as good and perhaps even a little bit better while minimizing radiation. And they're seeing a greater than 75% reduction. And that's on top of any kind of equipment you already have. And so that's to everybody in the room, So physicians, staff, and patients.
Yeah, because that's the thing is, first of all, hospitals need to cough up the money to pay for this, but it also needs to be physicians who take the extra steps. be it investing in certain structures that take the weight of the lead, or all these types of things that are out there. But one of the points you made with the eye tracking is that this is a sort of low barrier. It's not a big learning curve.
Right. There's no learning curve. I mean, literally, like within a second, all you have to do is look a certain way. You don't even have to put on glasses or anything like that.
Okay.
So the only barrier is cost again, and it's really
always.
going to come down to us as physicians, and hopefully our societies will also support this, that it kind of has to be a mandate that hospitals are going to step up and take care of risks in the cath lab. And
So have you guys convinced your hospitals to put protective measures in place?
I haven't.
If you guys haven't, I mean, what hope is there?
I know. Well, that's something that we have to keep working on. So,
Okay.
I mean, I think the equipment in general, we're lucky that industry's done a nice job in trying to lower it, but to add these extra things is a hurdle that we have to keep working on.
Dr. Mader?
Yeah, and our hospital system, learned the hard way of how expensive it can be to lose a physician to an injury. And
wow.
8 years ago when I started at Spectrum Health in Grand Rapids, one of our senior interventional cardiologists actually had his third spinal surgery, likely related to decades of wearing lead in the cath lab. And, the institution felt the pain of that physician being out of the lab for those many months. And so there's a very measurable financial burden when you
What
lose
did they
a
do about
physician.
it?
Well, we use that as a way to say, hey, is there anything we can do with some of these newer technologies, invest in them, bring them to our center to try to prevent these injuries from happening again, or at least mitigate the risk. And so we were able to purchase 2 robotic systems, and so we've been doing robotic PCIs in our cath lab now for over 5 years.
Okay.
We have purchased suspended lead systems. And so the majority of our interventional cardiologists now at our center do not wear lead suits anymore. We use the zero gravity system, and so it takes all of the orthopedic strain off of the interventional physician. And we have data that we published showing that it cuts the interventionalist radiation exposure by about 99% when you use those compared to traditional lead garments.
And your staff as well?
Yeah, so we took an interest in staff safety kind of as we were improving the safety culture of our cath
I remember
lab.
I covered a paper on this at one
Yeah,
point.
so we published
Your
in
group.
JACC Intervention a couple of years ago that something as simple as putting a 6-foot-tall acrylic lead shield, one for the nurse, one for the tech.
Okay.
Importantly, the one for the nurse is on the far side of the table where they typically will place the IV pole, and we showed that just using that shield is associated with about a 2/3 reduction in the dose to staff members, which they appreciate.
Sure.
I think one of the exciting things about the control rad technology that Jennifer talked about is all the shielding techniques that we use, whether it's robotics, whether it's zero gravity, whether it's just acrylic lead shields, they cut the dose for the operator and the staff, but they don't cut the dose for the patient. And the control rad is nice. I think that it does both of those things.
Yeah, I would add too that it's important if you're going to bring a technology in that requires people to change in any way, be it wearing different lead or obviously learning robotics, that the group is going to have to really be into it, because you don't want to put in that investment, and then only have some of the people use it or have everybody decide they don't like it, and that sort of thing. So again, I think something where it's kind of already built into the system and we all use it just by virtue of it being there and kind of don't have any choice may ultimately be the easiest way if groups can agree.
Okay.
Yeah, and I completely agree with that. I think there needs to be a physician champion for each of these devices when you bring these technologies in, somebody who's really going to make sure that it gets used.
Yeah.
And I think the other thing from an administration standpoint, if you as a physician advocate for bringing in some technology and then it sits in the corner and collects dust and nobody uses it, I think that's on the physician.
Yeah.
And it's going to be hard to go back to the well and ask for more.
Yep.
When the next technology comes out. So I think there has to be a physician that's willing to stick their neck out, advocate for this technology, and then make sure it gets used when it comes to the cath lab.
Well, I'm watching for change in this space because I feel like I've been writing about different innovations for radiation protection for years, and yet I hear often that they are not used and that people don't even wear the caps and all these types of things. So you guys are leading the charge, and hopefully will lead to some change.
We'll check back in next year.
Exactly. Hopefully next year, yeah. Thanks so much for telling me a bit about it today. I really appreciate it.
Thank you very much.
Yeah,
Thank you. And thank you for watching On Record.